Thank you for joining us for the Parenting at Mealtime and Playtime webinar. The Ohio Chapter, American Academy of Pediatrics, operates this program with the financial support of the Ohio Department of Health. The Parenting at Mealtime and Playtime program, also known as PMP, has continued to evolve over the past several years to offer the best possible resources to you and the families you serve. Today we are excited to share more information on the programs in Ohio. Today you will hear from Dr. Jen Valentic, a pediatrician from Medina, Ohio. Dr. Valentic will be speaking to you about electronic medical support records for the PMP program and pediatric obesity prevention. The Parenting at Mealtime and Playtime program is here to assist you in your discussions with families. We aim to provide tools that will make your interactions more meaningful in the limited time you have with them and contribute to positive, healthful behavior change. In order to access our resources, we recommend you visit our Ohio AAP website. This is the easiest way to access PMP materials. This is available for all public health professionals at no cost, and no login is required. When you visit the website, www.ohioaap.org/PMP resources, and click the box that best suits your role. If you are a community health worker that works with the care coordination system, you will find our handouts within CCS as well. The speaker has no financial relationships to disclose, and no off-label products will be discussed. Our mobile app has other resources that may be helpful for you or your clients. This mobile app is free for download in the App Store or on Google Play. When searching for the app, search for Parenting at Mealtime and Playtime, rather than PMP, to be sure to find the correct mobile app.
Hi, I am Dr. Jen Valentic, and I am a primary care pediatrician currently practicing in Medina, Ohio. I am a former participant of the Parenting at Mealtime and Playtime program and a current member of the PMP Advisory Board. While I participated in the PMP program, I learned some helpful tips and strategies within my practice's electronic medical record that allowed me to more seamlessly integrate the PMP program goals and ideas into my daily practice and workflow. I am happy to be able to share some of these ideas with you today. I do have to begin with a disclaimer and let the audience know that I am most familiar with and currently use the Epic electronic medical record system in my practice. I acknowledge that the viewers of this webinar and participants in the PMP program may utilize a variety of electronic medical record systems. I encourage you to work with your practice or team's IT professionals or support staff to incorporate the strategies that you find most feasible and valuable in supporting your obesity prevention work and participation in the PMP program. Over the last couple of decades, the advent and implementation of the electronic medical records system has revolutionized the practice of medicine. As these EMRs have evolved, healthcare systems and providers have worked to incorporate valuable customizations that better support providers in their endeavors towards optimal patient care. As EMRs have evolved, so too has a body of literature that demonstrates implementing supports within the EMR can improve identification and management of pediatric obesity. I will highlight several of these studies. To begin with, Bardia et al. Reviewed the records of adult primary care patients in the early 2000s and found that most obese patients did not have a diagnosis of obesity or an obesity management plan made by their primary care physician. They found that a diagnosis of obesity resulted in higher chances of an obesity plan being formulated. A second study I'd like to discuss was done by Keebach et al. They found that incorporating an automatic calculation of BMI percentiles for age and gender within the EMR increased documentation and management of overweight children. Finally, a study by Thacker et al. Investigated the impact of a standardized template used during well-child check visits in the Boston Children's primary care clinics. This template provided an automatic population of the problem list, medication list, allergies, body measurements, and vital signs into the clinic note. It also provided prompts for age-appropriate health topics such as nutrition, physical activity, sleep, elimination, along with other components of the well-child check, like developmental screening, social, and family history. The assessment and plan section included prompts related to weight management to be addressed in all children. Each section had predefined sentence prompts that were designed to facilitate history taking and documentation. This research group concluded that the use of this template was associated with improvement in rates of documentation of obesity without an interruption in provider workflow. Here is an outline of the topics we will cover in the rest of today's presentation. Several objectives I hope viewers will take away from this presentation are as follows: an understanding of the importance of growth charts in discussing health and weight status, a knowledge and understanding of smart phrase or dot phrases, as some call them, and how to implement these into your EMR system, an understanding of the importance of pre-visit planning, how to incorporate PMP resources into office visits, and a general understanding on the billing and coding of obesity-related diagnoses. We will begin our discussion with a review of growth charts. The Centers for Disease Control and Prevention, the CDC, and the American Academy of Pediatrics, the AAP, recommend that healthcare providers in primary care settings use the World Health Organization, or WHO, growth standard charts when monitoring the growth of children aged birth to less than 2 years, and use the 2000 CDC growth reference charts for children and teens aged 2 to 20 years. The links to the WHO and CDC growth charts, as well as trainings on these specific growth charts, are included on the slide for your reference. Clinicians may notice slight differences in how their patients are classified on the growth charts around the age of 2, as this is when the switch is made from the WHO to the CDC growth charts. Specifically with regards to length, patients 2 and up should no longer be measured using recumbent length, but height should be obtained using a standing height measurement. This adjustment may make it appear that a child has decreased in their height, but studies show that standing height may result in a measurement that is 1/4 inch shorter than the measurement done by recumbent length on the same child. Another important difference to note is that the WHO's reference population is primarily based on breastfed infants, while the CDC's reference population is primarily based on formula-fed infants. Clinicians may also notice a change in their patients' percentiles when moving from the weight for length curve to the BMI for age curve. This may be in part due to the recumbent length to standing height difference. Caution should be used in interpreting any change in percentiles based on a single measurement. Growth monitoring is best done over time when it is based on a series of accurate measurements rather than on a single plot on a growth chart. Finally, the cutoff values differ between the WHO and CDC growth charts. During my visits with families, I like to turn my computer screen and show the child's growth chart, as it provides a nice visual representation of growth trends over time. Oftentimes, I will ask for the parent's permission by saying, "Would it be okay if I reviewed your child's growth charts with you today?" Or just simply, "Would you like to see your child's growth chart?" Sometimes I find it helpful to open the discussion with a question like, "What do you think about how your child is growing?" Alternatively, I may review the statistics and trends on the growth chart and ask this question of the parent as a follow-up. An inquiry like this can help to know where the family is at and how you may guide the conversation going forward. When reviewing the BMI for age chart specifically, I like to explain BMI as a number that tells me how well matched the child's height and weight are. Depending on the growth trends, this may allow for a segue into the discussion on the health implications of BMI status. If BMI is trending up, you may consider a phrase or statement like, "It looks like their weight is increasing faster than their height. Their BMI is moving into the high-risk zone." As part of this discussion, you may also consider briefly inquiring about obesity-related conditions in the family history. If the family shares that there is a strong history of conditions like type 2 diabetes, heart disease, or high cholesterol, you may consider contextualizing the patient's BMI trends in light of their genetic risk for some of these obesity-related conditions. You may further the discussion from that point by utilizing several motivational interviewing strategies to gauge the family's readiness for change and interest in setting a SMART goal or healthy habits goal for the visit. This screenshot provides an example of a child's increasing BMI trend over the last few years. For Epic users, you may hover over any of the black dots and a box appears with the corresponding statistics. In this case, it indicates that this child has crossed the threshold to pediatric obesity with a BMI percentile over the 95th percentile. In our review of growth charts, I would also like to point out that specific charts exist for a variety of conditions that might affect your patients. For example, specific growth charts exist that allow clinicians to more accurately assess the growth of patients with conditions like achondroplasia, cerebral palsy, Cornelia de Lange, Noonan, Turner, Down, and Williams syndromes, as well as the growth of premature infants on the Fenton and Olson charts. For Epic users, these options are available in a drop-down menu on the right side of the growth chart. You may need to uncheck the Apply Patient Filter box and select from the drop-down menu. As I reviewed earlier in the presentation, several studies have demonstrated that documentation of weight status can help identify patients at risk for overweight and obesity and can thus affect their management. I will now briefly discuss some documentation tips for Epic users. However, I strongly encourage that viewers who use other electronic medical record systems inquire as to whether your system may allow you to incorporate similar strategies. As an overview, the Epic system utilizes several different types of SmartTools. SmartTools are charting shortcuts that you can use to pull different information into your documentation. Smart Texts are templates or blocks of text. Smartphrases are long words, phrases, or paragraphs that you can pull into your note using a shorter designated dot phrase or smart phrase. Smart links pull information from another part of the chart, like labs or vitals, for example. Smart lists allow you to select from a drop-down predefined list of choices. The graphic below the table on the slide indicates that the field is a Smart Tool enabled. This table lists a handful of helpful Epic smart phrases that may allow you to pull valuable statistics into your note for both ease of documentation, but it also provides a quick way to review this pertinent information during your patient encounter. The following slides will demonstrate what these smart phrases look like in an actual note. Here you can see the last weight 3, WFA, last height 3, and SFA. I would like to point out that the weight and height raw values are listed too, but also helpfully the age and gender specific percentiles are also displayed with these smart phrases. On the screen, you will see how the vitals with orthostatic smart phrase displays the vital signs in a succinct table form. This patient did not have orthostatic vitals obtained, but if so, these would pull into the table as well. Below the table, you will see that the .BMI phrase pulls in the raw BMI calculation as well as the age and gender specific percentile information. The .BPFA, or blood pressure for age phrase, pulls in the age and gender specific percentiles for the systolic and diastolic blood pressure measurements. It also lets you know if the blood pressure falls within the normal, pre-hypertensive, stage 1, or stage 2 hypertensive ranges. The .BPFAWR phrase goes one step further and provides targets for the 90th, 95th, and 99th percentiles. As a reminder, normal blood pressures fall below the 90th percentile. Pre-hypertensive blood pressures fall within the 90th to 95th percentiles, or greater than 120/80 for teens. Stage 1 hypertension is blood pressures that fall above the 95th percentile, and stage 2 hypertension involves blood pressures that fall greater than the 99th percentile plus 5 millimeters of mercury. The .BMI lab results phrase pulls in obesity-related lab results for the last 3 years. The lab tests included in this smart phrase are listed in the table on the right and include glucose, hemoglobin A1C, ALT, AST, TSH, and lipid panel components. Consistently adding a BMI-related diagnosis to well-visit documentation is an additional strategy that providers may pursue to ensure the topic is discussed with families. It may also allow for long-term follow-up and increase the chance that overweight or obesity may be identified and thus managed. If you often type the same phrases and sentences while charting, creating a custom smart phrase can save you time in the future. Instructions for creating a smart phrase are outlined on this slide. You may highlight the text you would like to make into a smart phrase and then click on the green plus sign. You will then select a name for your smart phrase. It is recommended that you begin the name of each smart phrase you make with your initials so you can find your custom smart phrases more easily. You can also view all of your smart phrases and create new smart phrases in the Smart Phrase Manager by clicking on the drop-down link at the top left of your Epic window as shown in the screenshot here. Here is a screenshot of how you may create your own smart phrase within the Smart Phrase Manager. I would also like to point out that you can share this smart phrase with others by listing additional owners in the box on the bottom right. Smartlists are lists of common choices from a drop-down menu that help you quickly customize your documentation. You may browse the variety of smart lists that may already exist within your Epic system, or you may create your own custom smart list by clicking on the New User Smart List as circled in this slide. When you make your own smart list, you can enter in each custom choice or option that will appear in the drop-down menu. Again, I encourage you to begin the name of your custom smart list with your initials. You can indicate if only a single or multiple selection can be made from your custom smart list in the Select Options field on the right. Smart lists can be included in your custom smart phrases as well, as shown here. Start by creating a new smart phrase. When you would like to add your custom smart list or drop-down menu, type in the name of the smart list you just created in the Insert Smart List box. These smart phrases and smart lists can allow for easier documentation and review of important information during your patient encounters. Another support tool that may already exist or you may consider incorporating into your EMR is called a Best Practice Alert, or a BPA. At my institution, a warning box pops up when the patient chart is open to alert the provider if a patient's BMI status is over the 85th percentile. This prompts the provider to add the appropriate BMI diagnosis to the problem list. This diagnosis can also be added to the list of visit diagnoses as well, as we have previously discussed. One final EMR support tool you may consider incorporating are order sets, or in Epic, these are known as Smartsets. Order sets or Smartsets are a one-stop shop for pertinent diagnoses, orders such as labs and imaging, instructions, follow-up info, etc. that might pertain to a specific topic. In a WellCheck or Obesity Smartset, you may consider including BMI diagnoses and other common obesity-related diagnoses, as well as lab orders like A1C, lipid panel, AST, ALT, and or glucose monitoring labs. You could also include standard patient instructions, for instance, text that outlines instructions on fasting for the labs you have ordered. You may also include a standard follow-up timeframe selection like 3 months, for example. Another topic I would like to discuss is that of pre-visit planning. Pre-visit planning is a process done in advance of a patient's appointment, perhaps done by a provider, nurse, medical assistant, or other support staff within your office that allows patient data to be collected and organized. This process allows for smoother visits for patients, staff, and providers. Pre-visit planning can take place on paper or can be incorporated into the EMR. For topics specifically related to obesity prevention, you could consider including a weight status statistic such as BMI or weight for length in your pre-visit planning process. Work with your team to determine where your staff may pull this data from. The last growth curve? The last provider note? Was the BMI status discussed at the last appointment? Were any goals set? Having this information on hand or in advance of the patient's appointment can save providers time from needing to chart review during the visit and may help guide the discussion or goals the provider may have for the visit. Providers, including this information in your current visit documentation can help with the pre-visit planning process and goal tracking in future visits. In this next section, I would like to offer some suggestions for incorporating the PMP handouts into your well visits. As a reminder, the PMP handouts can be accessed on the Ohio AAP's PMP Resources website. These handouts are also accessible in the PMP app. Let's review a case. You are seeing a 4-month-old female for the 4-month well child check. The infant is breastfed and mom has heard from friends that she should start solids now. She wonders what your thoughts are. In my own practice, I routinely cover the topic of solid introduction during the 4-month visit. I find that the PMP 4 to 6 month age-specific handout and the transition to solids handouts review much of the information I verbally cover with families. I will often come with printed copies of these handouts so that I may review them and provide to the caregiver present during the visit. As part of the pre-visit planning process, these handouts could be printed and prepared so that they are ready for the provider to take into the room. Alternative options are to ask the front desk staff to keep printed copies of these handouts that can be provided when the family checks out. You may also consider including these handouts in the patient's after-visit summary, or send these handouts to the family via a MyChart message during or after the appointment. Additionally, you could encourage families to download the PMP app where most of the handouts are easily accessible. I will review how you may include these documents in the after-visit summary or in a MyChart message in a few upcoming slides. As another case example, you are seeing an 8-year-old for his yearly well child visit. During your review of the growth chart with the family, you notice a sharp incline in his weight and BMI. You do some brief motivational interviewing with the family, and they share that he seems to struggle with portion sizes. They are interested in learning helpful strategies to mitigate overeating, but they would also like to gain an understanding of how much of each food group their child should be offered at mealtime. I really like the proper portions parenting at mealtime and playtime handout in this scenario. I appreciate the My Plate graphic as well as the hand graphics that visually demonstrate appropriate portion sizes for the various food groups. If you would like to send PMP handouts to your families in a follow-up MyChart message, you may start a patient message in the MyChart Utilities tab within Epic. Write the body of the message to the family, and on the right side of the screen, click the Attachment section. Adding an attachment allows you to browse your computer or cloud-based drives, like OneDrive for example, so you can select the PDF version of the pertinent PMP handout from a folder or location where you have the PMP document saved. It is important to note that you will need to download and save the PDF versions of the PMP handouts from the Ohio AAP PMP website. Consider creating one folder on your computer to house all of these documents so you can easily browse, access, and select them during this process. Once you have selected the pertinent PMP handouts, you will see them listed in the attachment box as shown here in red. You can then click Send to deliver this message and the handouts to your patient. In the next few slides, I will show you how to include the PMP handouts in your patient's after-visit summary, or the printout they receive at checkout. Start in the Patient Instructions tab and click on the star icon in the left upper corner. Select Insert Linked Image from the drop-down menu. From here, you will need to locate the area on your computer where you have the PMP handout saved. For this process, it is important to note that JPEG versions of the PMP handouts are needed. The JPEG versions of the PMP handouts will be available for download on the PMP website soon. Consider creating a folder for the PDF versions of the PMP handouts as well as the JPEG versions so you can easily access them. Here you can see I have selected the PMP 4 to 6 month JPEG file from my computer. An image of this PMP handout is now included in my patient's after-visit summary that will be printed at the checkout desk. You can see a preview of the AVS here. If you prefer to encourage families to access the PMP handouts within the PMP app, you could consider including this SmartPhrase text in your after-visit summaries. While this webinar is not focused on the topic of billing and coding, I will briefly cover some pertinent highlights, especially as they pertain to the recently implemented 2021 AMA coding changes. This table highlights the changes that were made in the 2021 coding guidelines for E&M visits. I would like to point out that, with respect to coding with time, total time, including non-face-to-face time such as chart review and documentation, may be included when you select your code as long as it was time spent on the date of the visit. I would also like to point out that the history and exam requirements are now only required as the provider deems medically appropriate and are not components of the code level selection. These tables further outline the medical decision-making complexity and/or time requirements that correspond with each E&M code level. The time requirements, or total minutes spent, were adjusted in the 2021 coding guidelines. If you address a significant problem or abnormality during a preventative medicine visit over and above what you might normally cover in a routine well or preventative visit, you may bill for this additional work using a Modifier 25. You would first include your well visit code, then select an appropriate E&M code at the level of 1, 2, 3, 4, or 5, depending on the time spent or complexity of the problems addressed. A Modifier 25 would be added to the visit, and the E&M code could be linked to the appropriate visit diagnoses that were the significant problems or abnormalities addressed. This slide lists some of the obesity-related ICD-10 codes you may consider including as additional visit diagnoses. A more complete list of obesity-related ICD-10 codes is available on the PMP ICD-10 coding fact sheet, which can be found on the PMP website. This coding fact sheet is in the process of being updated with the revised 2021 coding guidelines. I will conclude this presentation by briefly covering some of the resources that you may find helpful as a provider and helpful resources for the patients and families you work with. To begin with, you may consider including a link to the PMP app and the PMP parent website on your practice's website. The Healthy Active Living for Families, abbreviated HALF resource, is a project of the American Academy of Pediatrics with the goal of addressing early childhood obesity prevention that integrates the parent perspective and evidence-informed pediatric health guidance. There are numerous resources available on the HALF website, including a Quick Tips, Keep Your Child Healthy widget, and a Are You Raising a Healthy Child quiz widget. You could consider linking to these resources or even consider embedding the widgets into your practice website. Instructions for doing so can be found on the HALF website. Listed here are links to several resources I have found and recommended to families to increase physical activity at home and for nutrition information and healthy meal or snack ideas. For providers, the AAP Institute for Healthy Childhood Weight offers many resources, including a great podcast called Conversations About Care. The HALF program also offers educational mini-modules that providers can complete to earn MOC Part 2 and CME credit. Thank you for the opportunity to speak with you today. I hope you have learned some helpful tips that may enhance your obesity prevention work and experience with the Parenting at Mealtime and Playtime program.
We sincerely appreciate you spending your time with the Ohio AAP to learn more about these important topics impacting children's nutrition and play. You can access the Parenting at Mealtime and Playtime resources on our Ohio AAP website. Thank you to our presenters for all they do for the Parenting at Mealtime and Playtime program and for Ohio's children. If you have any questions for Ohio AAP, please don't hesitate to call us at 614-846-6258. A big thank you to you for your ongoing efforts to assist Ohio's families.